Hello, my name's Roger Henderson and I'm a GP, and I also co-host the GP Notebook study groups. Welcome again to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. Now, in this episode, I want to discuss tremor, because this is something that we so frequently encounter in our surgeries. But despite how common tremors are, they can still be diagnostically elusive and therapeutically challenging. So what I'd like to do in this podcast is take a quick walk through the underlying mechanisms, clinical presentations, diagnostic strategies, and the current treatment approaches for the various tremor syndromes that we all encounter in our surgeries. So let's begin with the basics. Tremor is defined as an involuntary rhythmic oscillation of one or more body parts mediated by alternating contractions of reciprocally acting muscles. They commonly affect the upper extremities, but they can also affect the head, the chin, the voice, or the legs. Now, what's really important to remember here, though, is that tremor is a symptom and not a diagnosis in itself. It's simply the outward manifestation of dysfunction in certain motor circuits within the brain. Understanding which part of the brain is misfiring helps us figure out the type of tremor we're dealing with, and I've found that's the key to successful treatment. The pathophysiology of tremors is interesting but really varied. So, for example, essential tremor, which is almost certainly the most common pathological tremor, is believed to arise from abnormal oscillatory activity in the cerebello-thalamocortical loop. On the other hand, a Parkinsonian tremor stems from the degeneration of dopaminergic neurons in the substantia nigra, and this affects the basal ganglia circuits, altering the normal inhibition and facilitation of movement. Cerebellar tremors are linked to damage in the cerebellum itself or its output tracts, particularly things like the dentate nucleus and its connections. Now, when it comes to classifying tremors, there are several ways to do it, but in my experience, the most practical thing to do in our surgeries is to ask the patient when the tremor appears. So, a rest tremor, for instance, shows up when the affected limb is fully supported and not being voluntarily moved. So, that's typical in Parkinson's, for example. Postural tremors happen when the patient is holding a position against gravity, such as when their arms are outstretched, and essential tremors would fall into this category. Kinetic tremors appear with voluntary movement, and within that group I would include intention tremors, which become more prominent as the person approaches a target. So think of the classic finger to nose test here in someone who has cerebellar dysfunction. There's also isometric tremor, which we see when a muscle contracts against a fixed object but doesn't move. Now, this one's less commonly discussed, but it can show up in certain contexts. It might also be worth paying attention to a patient's tremor frequency and amplitude because, for example, physiological tremors tend to be high frequency and low amplitude. Parkinsonian tremors usually run at around 4 to 6 Hz, while essential tremors are that little bit faster, around 6 to 10 Hz. So now let's walk through the most clinically relevant types of tremor one by one. And I'm going to start with essential tremors here, as the vast majority of tremors that we see in primary care are these. Now, in the past, these have been called benign or familial essential tremors, but I do feel the term benign is now inappropriate, as these can be very troubling and even disabling in some patients. An essential tremor is often a bilateral, symmetric, postural or action tremor that typically affects the hands and the arms, but can also involve the head and the voice, and that can be very distressing for some people. They do have a tendency to run in families, and they can temporarily improve with alcohol, which is something many patients discover on their own, which can be a useful little diagnostic tool for us. Now, what's key here with these tremors is that you won't see any rigidity, bradykinesia, or gait instability early on, and that helps to differentiate essential tremors from Parkinsonian tremors. Essential tremors tend to be progressive, slowly worsening over years, and they can significantly impact daily tasks such as eating, writing, or drinking from a glass. And the numbers are not insignificant. It's thought to affect about 0.5% of the population, with men and women being equally affected. The onset of a familial essential tremor is typically during childhood, whereas sporadic essential tremors usually occur over the age of 40. Next, I'd probably go for the Parkinsonian tremor, and these usually begin unilaterally and are classically described as a pill-rolling motion of the fingers at rest. Now, if these aren't immediately apparent in your surgery, it may be induced by asking the patient to concentrate, and I ask them to tell me the months of the year backwards. Tremors usually apparent in one limb or the limbs on one side for months or even years before becoming generalized. And as with the other Parkinsonian features, it may later become bilateral. The key difference from an essential tremor is that Parkinsonian tremor is more prominent at rest and more likely to be absent during activity, and usually comes with other symptoms such as rigidity, bradykinesia, and postural instability. Sometimes, though, the tremor is the dominant or even the only feature for years, which can sometimes make an early diagnosis more difficult. Now, cerebellar tremor is a different beast altogether, and this typically presents as an intention tremor, meaning it worsens as the hand approaches a target. And this is because of damage to the cerebellum or its pathways, often due to things like multiple sclerosis, stroke, trauma, or tumours. And patients with a cerebellar tremor usually have other signs as well, such as nystagmus and truncal ataxia. One little tip here to remember is that the writing of someone with a cerebellar tremor may be larger than normal, which is in contrast to the micrographia that we see in Parkinson's disease. Then we have a dystonic tremor, which in my experience can be particularly tricky to diagnose. These patients have tremor in a body part that also shows signs of dystonia, abnormal, often twisted postures due to sustained muscle contractions. And this tremor tends to be irregular and may vary depending on posture or action. And patients may also learn to use a sensory trick, like touching their chin to reduce their tremor. And this little tip may help you to distinguish a dystonic tremor from the essential or Parkinsonian types. Drug-induced tremors are much more common, especially with medications like valproate, lithium, SSRIs, and antipsychotics. And these tremors are usually symmetric and postural, and usually improve when the offending agent is reduced or stopped. Drugs can cause tremors at rest or during movement. So drugs causing a rest tremor include dopamine receptor blockers, atypical antipsychotics, anti-nausea drugs, calcium channel blockers, and dopamine depleters. Those drugs with the potential to trigger an action tremor include antidepressants, mood stabilizers, antiepileptic drugs, amiodarone, immunosuppressants, salbutamol, theophylline, and amphetamines. Now, personally, I find one of the most diagnostically challenging forms of tremor is a functional psychogenic type. And these tremors often begin suddenly, they vary in frequency, and this is inconsistent during an examination. You might notice that the tremor disappears with distraction, or it can be entrained, meaning the tremor changes to match a rhythm that the examiner imposes on the contralateral limb. And these features all suggest a non-organic origin, and management of these usually involves psychology and physiotherapy, not medication. I think it's worth mentioning lastly that an orthostatic tremor can occur, but this is a rare but distinct entity. So here, patients complain of unsteadiness when standing caused by a high frequency tremor in their legs and trunk. But the interesting thing here is that this type of tremor usually disappears when the person starts walking or sits down. And these can be confirmed using an EMG or a surface accelerometer, which will show a rapid 13 to 18 Hz tremor. Now, as so often is the case in medicine, when we approach a patient with tremor, clinical evaluation is the single most important step. A good history and a good neurological examination can often get you to 80 to 90% of the way to a diagnosis. So, you should always want to know when the tremor started, how it's progressed, whether it runs in the family, and whether it's affected by medications or substances such as caffeine, alcohol, or stress. I would always do a full screening peripheral neurological examination where I would check the muscle tone, power, coordination, reflexes, and sensation, and I would also always ask the patient to walk so I can observe their gait. Do remember to test for any rigidity and bradykinesia, suggesting Parkinsonism, and to check cerebellar function by assessing their speech. And using a simple tongue twister can be rarely helpful here. Also check their balance, finger-nose pointing, and dysdiadochokinesia, the inability to rapidly alternate movement. So, for example, pronation and supination of the hand at the wrist held on the outstretched contralateral palm. Do a simple cranial nerve examination too to pick up any underlying neurological disease, and observe the tremor at rest, in posture, and with action, and to check for any functional inconsistencies throughout this time. Now, sometimes investigations are warranted, but certainly not in every case, or if there's a characteristic presentation of an essential or physiological tremor and you're happy with that diagnosis. But I would always check a thyroid function if you suspect thyrotoxicosis, and I would order a ceruloplasmin and copper studies in a young adult where Wilson's disease is a possibility. An MRI of the brain may be useful if you're concerned about a structural lesion, and if you're having trouble distinguishing an essential tremor from a Parkinsonian tremor, then a DAT scan can be helpful, as this shows reduced striatal dopamine transporter binding in Parkinson's, but is entirely normal in an essential tremor. So turning to management of a tremor, in an essential type, if this is mild and there is no functional or psychological disability or handicap, then no treatment should be required apart from reassurance. But if medication is considered necessary, then the mainstays of treatment here are propranolol and primidone. Both are effective, and many patients respond well to one or the other, but we mustn't forget they can cause side effects, especially in the elderly. Now, if these don't work or they're not tolerated, other options include topiramate, pregabalin, and sometimes rarely even benzodiazepines, although Cochrane reviews have found insufficient evidence on both the efficacy and adverse effects of treating essential tremor with these. For focal tremors, especially with things like a voice or a head tremor, botulinum toxin A injections can be very helpful. And in cases that are refractory to medical therapy, surgical intervention is now possible, with deep brain stimulation of the ventral intermediate nucleus of the thalamus proving highly effective in reducing tremor amplitude. Another option is MRI-guided focused ultrasound thalamotomy, especially for patients who can't or don't want to undergo invasive surgery. For a Parkinsonian tremor, levodopa is obviously the first-line treatment and generally quite effective for bradykinesia and rigidity, although its impact on tremor can be more variable, and some patients respond better to dopamine agonists like pramipexole or ropinirole. In younger patients, anticholinergics could be considered, but obviously in older patients we tend to avoid them if possible due to the increasingly known risk of cognitive side effects. Again, in medication refractory cases, deep brain stimulation targeting the subthalamic nucleus, or globus pallidus internus, can provide excellent tremor control. Now, unfortunately, unlike Parkinson's disease, a cerebellar tremor is often resistant to medication. Some agents, like clonazepam, levetiracetam, or 5-hydroxytryptophan, have shown mild benefit in small studies, but I'm afraid these results are inconsistent. And physical therapy is crucial here to help our patients with this type of tremor adapt. But again, in severe cases, surgical intervention like deep brain stimulation may be tried, although these outcomes do appear to be less robust than with essential tremor. A dystonic tremor can be treated with medications like anticholinergics or benzodiazepines, but in my experience, botulinum toxin A is often the most effective here, particularly for cervical dystonia, which can be a very distressing condition for anyone suffering from it. In generalized or medication refractory cases, again, deep brain stimulation that targets the globus pallidus internus can be effective. If we're looking at a drug-induced tremor, the obvious best course is to discontinue or to reduce the offending agent, as this should simply clear the problem. If that's not possible, though, beta blockers can provide symptomatic relief. Functional tremor management requires a multidisciplinary approach, and the key here is in helping our patients understand the diagnosis and engaging them in physiotherapy and cognitive behavioral therapy. It's really important to say we should always try to avoid unnecessary medications or invasive interventions with a functional tremor if at all possible. Now lastly, for an orthostatic tremor, clonazepam is usually the first-line treatment, sometimes followed by gabapentin or primidone if needed. And these patients also often benefit from walking aids or support belts to improve their postural stability. So just pulling this together then, tremors are common but incredibly diverse in their underlying causes and clinical features. And a careful, systematic approach to the diagnosis, guided by activation patterns, associated neurological signs, and key features from the history will help us accurately classify and manage a tremor. We should remember that treatment must always be individualized to each patient, and while pharmacological options still remain the first step usually, surgical therapies have transformed the outlook for many patients with a refractory tremor. So I do hope you found this podcast on tremor helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments, or ideas for future podcasts. We really do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.